One of the themes of this EBMT meeting has been to try and work through strategies with the potential to reduce the risk of disease relapse after an allograft for AML. We know that the toxicity of transplants reduced substantially over the last 30 years thanks to improvements in supportive care, in tissue typing. We also know that there has been increased availability of donors, so now almost every patient with high-risk AML has a potential donor, and yet up to 70% of patients are destined to relapse. So when one comes to think about how you might reduce relapse, there are a number of approaches. We know that pre-transplant MRD is an important predictor of disease recurrence, so there's consideration about whether one could optimize the MRD status prior to transplant. There's considerable interest here in the design of an assessment of novel conditioning regimens. But one of the areas of most hope, I think, is trying to understand whether we can optimize a graft versus tumor effect after transplant. And very simply, there appear to be at least a couple of approaches that can be employed. The first is that we know that significant numbers of patients relapse almost by definition before the development of a significant graft versus tumor effect. So the question arises as to whether by manipulating the kinetics of disease recurrence, in other words, delaying disease relapse, not eradicating it necessarily, but delaying it, you buy time for the genesis of a potent GVL effect. And there's some very interesting data emerging now with FLT3 inhibitors, which are being tested in a prospective study by the US CTN group, randomizing patients to post-transplant gilteritinib maintenance or not, patients with FLT3 ITD positive AML. The other area of considerable interest is whether we can pharmacologically manipulate the graft versus tumor effect. And there's some very encouraging in vitro data using azacitidine and indeed recently decitabine, demonstrating that you upregulate tumor antigens, plausibly increasing a graft versus leukemia effect, and possibly also reduce the risk of GVHD by increasing expression of FOXP3, which is a aberrantly methylated, which is has a methylated promoter. FOXP3 is clearly an important transcription factor driving Treg production, and there's good animal data and clinical data that application of azacitidine post-transplant accelerates Treg reconstitution. So again, what we need, given the encouraging phase 1/2 studies, is prospective data to assess this important question. There may be other ways in which drugs can manipulate the graft versus tumor effect, and one of the most interesting papers in this regard in the last couple of months was in Nature Medicine recently, showing that the FLT3 inhibitor sorafenib, through production of IL-15, may accelerate CD8 T cell reconstitution and function post-transplant. So taken together, whether it's by delaying relapse and buying time, or whether it's by manipulating the graft versus tumor response, this is clearly an area of great promise. But what's become abundantly clear is we have to deliver randomized prospective studies with integrated biology at pace and at scale if we're going to assess in the speedy time that our patients demand whether we can improve transplant outcome. And what's been striking at this meeting has been the data that is generated through the 7,000 patients randomized by the US CTN, Clinical Trials Network, highly effective mechanism for delivering practice-informing studies, and it's, I hope, going to be mirrored by the UK initiative, the establishment of the Platform for Accelerated Clinical Trials in Transplant, IMPACT, which was launched last year and will be opening its first 3 clinical trials this year.